All right, so let's briefly talk about some abdomen and GI pathologies, and we're going to spend most of this time reviewing some x-rays. So we have our list here. It can also be found in Canvas, and all of these are presented to you on the PowerPoint for this week. The big takeaway from this is going to be the ability to define the following pathology and mention whether or not they need a technique change. Now, on the PowerPoint, I've done something differently than in previous weeks, which is I haven't put the up or down arrows generally, because for all of these pathology, we generally just increase KVP. If you'll remember, for this area of our body system, all of the tissues are relatively the same. So they kind of show up the same on an x-ray. So what we have to do is introduce contrast media. Basically, we're introducing a high atomic number so that when x-rays go and interact with this anatomy now, with that contrast introduced, it can give us a lot more detailed information. What that means is whenever contrast is used, we generally just use an increase in KVP to get our diagnostic image with that contrast in there. So let's go ahead and take a look at our next slide here. We're going to identify a few things on radiographs, and one of your challenges this week also is to identify the most common cause of bowel obstruction in adults and children. So I'm going to go ahead and let you know that for adults, it's mostly fibrous adhesions, which cause an adynamic ileus. So this is going to be your answer here. Fibrous adhesions are things that happen to the bowel as a result of maybe a surgical procedure or trauma or different things that cause maybe scarring or these fibrous adhesions on the bowel. What that can do is eventually cause the bowel to stop creating peristalsis, which is a involuntary, just natural movement of our intestines to move contents along. For children, it's going to be intussusception. And let's go ahead and see what that looks like on an x-ray. This is going to be intussusception right here. Characteristic of it on an x-ray is telescoping. So we can see all these concentric circles here showing us telescoping. And to help you remember that, you can remember maybe the old telescopes that you sometimes see in older movies based in older times, where the telescope can collapse into itself and then extend as well. On the next x-ray we have is diverticulosis. Now it's very important not to mix this up with diverticulitis. Itis, that ending on that word implies that it's an inflammation. So diverticulitis is going to be a complication of this, which is diverticulosis. Sorry. And all it is outpouchings along the wall of part of our digestive system. All these little outpouchings here. That's diverticulosis. Now on our next x-ray, I just brought it up so that you can compare. Now where we have diverticulitis. So now we have that itis ending on our word, and we can see that it looks quite a bit different. Here it looks like the condition has eaten away at the bowel for this one. On our next x-ray, we're going to look at annular carcinoma. Annular carcinoma is characterized by an apple core appearance. That's what they say anyway. So we can see that this type of cancer has eaten away at the bowel here. So instead of it having its natural lines here, it has, again, eaten away at the tissue in these areas. And our last but not least x-ray here is going to be of a hiatal hernia. And I'll write that here for you. Hiatal, hernia. So instead of the stomach being below the diaphragm, we see the diaphragm here. Instead of the stomach being below that diaphragm, now it's found a way up through looks like the esophagogastric juncture to go up into the chest cavity through that little opening. It took an opportunity to pass through the diaphragm up into the chest cavity.